Green.
Well, you said herbs, not to mix herbs with it. What about like vitamins D, A,
Yeah, I mean, as far as we know, the standard vitamins are fine.
magnesium?
Yeah, magnesium is fine.
Yeah, most vitamins and minerals.
No, the thing about
It's just the herbs that you don't have.
Don't get us wrong. We're not up here on the pulpit about herbals and stuff. All we're saying is we do not know. We do not know how lots of these over-the-counter herbs and preparations.
They haven't been studied. You haven't had a
How
chance.
they might impact your ability to respond well to that, expensive therapy. So all we're saying is during the time that you take this treatment, we would recommend not being on any of this stuff because it could affect how those drugs work in your body, how those prescribed
But
drugs.
it was okay to take calcium or
Calcium's fine, and magnesium, all those supplements, those minerals and
vitamins.
and a multivitamin is fine. Yeah. Back in the corner.
Medical marijuana.
Medical marijuana. How are you doing with your medical marijuana? Are you doing okay?
I plead the fifth. Okay. So,
He's pleading the fifth. All right. Again, that's one of those things where it's not very well studied. I'm sure that there were people taking, marijuana who were on some of these treatments. It's not been studied yet whether some of those people who failed therapy might have been users of marijuana. There's just no data on it. So, if someone's, we consider it not a contraindication to therapy, and if someone is on medical marijuana, we treat them through that. And as far as I know, we've had good response rates whether or not they take marijuana, I think.
yeah,
But we haven't really looked at it very well. So
yeah, and it's incredibly hard it would be incredibly hard to study that just with doses and how much the patients are actually taking. We have patients say that they're using it. We have patients say that they're not using it. We haven't seen any huge difference, but we also aren't specifically studying that.
So if you want to join us and study that, maybe Jacob's got a position for you.
There you go.
The marijuana intervention core, something. Okay.
There you go.
Yep.
What about anti-rejection meds?
Yeah, anti-rejection meds, now you're talking more in the realm of clinical decision making. And this is where clinical pharmacist is really important because so far the interactions with the anti-rejection meds are all manageable, but they have to be managed. So being on anti-rejection meds is not a contraindication to treatment, but we do have to pay attention to the prescriptions, and we may have to alter immunosuppression drugs depending on what drug it is and what doses and so on and so forth. So it's something that your transplant team is well aware of, and they can modify the prescription accordingly. But your prescription on your immunosuppression meds may or may not have to be altered depending on which of the new drugs that you're treated with. This gentleman here.
How much are these insurance companies picking up with this cost now? Like Kaiser and places like that? I know it depends on your deductible and everything.
Yeah.
But Kaiser's involved in it now, right?
Yeah. Oh, yeah.
Okay, and what about like the VA? Like someone like me that could go to Kaiser. I've got Kaiser insurance, but I've also got the VA.
I think for both those it's pretty good. Here, Jacob. Yeah. I think you're in good shape there.
Yeah, in general, the VA has a really good system. TRICARE has been very good with covering patients, and we've had a lot of success with that. Usually with Kaiser, they have to be treated at a Kaiser facility, so then they leave university and go get treated at Kaiser, but then I believe they have been covering, so you just don't get to see us.
Yeah, and in Kaiser it'll depend on your plan, in terms of
completely.
What your copay will be on that. So
Right,
some of
what
those
about,
copays can be.
What
pretty
about
high.
like the VA? I mean, the VA is free. Is that free? I've never used the VA before, but I've got
well, if you it depends on when you go into the VA system, they give you a rating.
Yep.
And then based on your rating, it'll determine what you would be covered under.
Does that have to do with your income?
I think it has to do with your level of service, how long you were in the military, how you were discharged, what kind of whether you had service connectedness or not, things like that.
Vietnam era, 4 years, like that.
I think you should check it out. Yeah, I'd check it out if I were you, because I suspect that you might have full coverage there. The gentleman in the back.
With these companies that are developing these new drugs for treatment, I'm assuming that they are patenting their products, and those patents only last a certain amount of time. Can you tell me how long that patent lasts before the drugs can be produced by other companies in competition?
I know a little bit about this, but maybe not in the drug specifically. Do you know the exact answer to that?
The exact answer is there is no exact answer. It really depends on what the disease state is, and it's all determined by the FDA. In general, 7 to 11 years is a range of patents, but it's very much specific to that disease state and that drug. But it does patent last for a certain period of time, and then other companies can produce what are called generics. And then at that point in time, the price usually drops.
So we could be looking at 10 years before some of these prices come down.
Well, right now there's only one of these combinations in the marketplace, I guess, if you want to use that term. And should be a second interferon-free regimen available by the end of the year, maybe a third sometime next year. So I think you might see some competition and price adjustment there. And then after that, you're going to see probably adjustments related to the payers interaction, which will happen probably over the next year. And then you'll see 1 or 2 or 3 more, companies coming in with different products. So I suspect in a couple of years, we'll be looking at over the next 2 years, I think there'll be a gradual, significant reduction in cost of cure. But maybe I'm optimistic.
So the one that the Sovaldi that's
Yeah.
approved now, then there's going to be another one approved maybe by the end of the year.
Well, you can't really say because the FDA has not yet ruled on it, but the odds are that's yes.
Yeah, going by what you see possibly happening, are these drugs being manufactured by different pharmaceutical
Yes.
companies? Okay.
Yeah, they're different companies, different alliances, Yeah, and so in some cases, these companies cooperate. Like in the HIV world, sometimes they'll put together combination therapies.
Well, that's one of the problems is that they cooperate.
Okay, yeah. Well, I don't think we shouldn't, badmouth completely, because the only way that we've gotten to this cure is through the R&D that happened. We could be looking at interferon today very easily if there hadn't been a big expenditure of capital resources into pursuing the cure. Because there's a balance here. We can't just look at the cost of a pill and say that that's exorbitant. If they had come in and said the pill isn't $1,000 a pill, it's $888 a pill, it would never have gotten to the press. And the other side of it is, in terms of biologic therapy today, the biologics are much more expensive than this stuff. And the cancer treatments, the rheumatoid treatments, the anti-inflammatory treatments, the infusions for Crohn's disease and ulcerative colitis, all these things are super expensive. Now, I'm not justifying the cost structure. It'd be great if we could look at it in an objective manner and everyone could be happy and the prices could be down. But the fact is that we're kind of isolating on a topic that has the risk to obscure the real thing you want. The real thing you want is not a debate on cost. The real thing you want is a debate on cure. Because you guys and patients, there's 5 million people. What you want is a debate on, go ahead and lower the costs. But really what I want access to this, and I want to be cured of hepatitis C. So I think that's the louder voice that needs to be heard. If you focus on just the cost aspect, I don't think you win the battle. But if you focus on, hey, we're people with a chronic condition that can be cured. Name one other chronic condition that can be cured. And if you don't cure me, if you don't help us pay for this now, cure me now, you're going to pay for me later when I'm in your ICU and in your ER and in everything else and in your transplant centers. You know, we've got to get off this. We're stuck on home plate. We hit the ball, and we're waiting to run. You know, so I don't know how to frame it. I don't have all the answers. Don't get me wrong, but I do think to get some movement, to get coverage, requires the personal factor that you have with your governmental agencies and legislatures and whatever. But I think there's a voice that you need to speak up for the fact that you can be cured. You know, I mean, if you all had cancer, and we had a cure for cancer, would you be focusing on the price of one pill? I don't think so.
That was well said.
We have to be realistic. We have to pay for this stuff. But I'm just saying, you know, we got to kind of refocus the discussion a little bit. Yeah.
I'm sorry, I got lost over a long way. Is Harvoni available now?
Yeah.
And the 3D is what?
3D is the one that will. I'm not sure what the name will be. I don't think I've seen the name. So it's it's due for this. Well, the first date I heard was December 10th, but I've also heard.
After the college, hepatologist, everybody meets in November.
No, it has to do with the FDA. The FDA sets a date, and they set a date of December 10th, but I think they've moved the date up. So I'm not sure what the actual date is. Do you know? Is there? Yeah, it's not.
I don't think there's an actual date. I've heard in the next month or so.
Okay. Is there a name besides the 3D?
Not yet.
Just
There will be.
There will.
It hasn't been announced. I don't know it.
Nancy.
All right, so one of the ways we encourage people who don't have insurance to get coverage is to go through clinical trials. So I'd like Dr. Everson to talk about the clinical trials that he's going to be recruiting for in the next year or so, and just think about it as an option if you don't have health insurance, or if this looks like it might be a good way for you to go.
This is one place where Medicaid patients probably have an option, you know, because so I think you saw my disclosure slide, all those companies and stuff. I don't have a separate account in Bermuda where that money gets dumped. Although I wish maybe I did sometimes, but all that goes through the Grants and Contracts office of the university. I've never had a separate account for any of that stuff. So this is not like a private enterprise run on the side. So what we do is through the Grants and Contracts office at the university, we contract with pharmaceutical companies to do their clinical trials. And basically the money that goes into that supports my coordinators and pays for your treatment and all your clinical care. So if you go into a clinical trial, that money that comes in is used to provide all your treatment, all your blood tests, everything, okay? It doesn't even pay my salary, so I don't even collect salary support for it for the most part, maybe 1%. Anyway, so the studies we're doing now, I would say a lot of the focus tends to be more in advanced disease, you know, more of the fibrotic, cirrhotic population. We probably have anywhere from, I think we have about 6 studies coming up that will be looking for patients. Now I must say, obviously, a lot of patients want these trials. So there's definitely a waiting list for just about every category of Hep C. So that's one of the problems. It's not as accessible as it used to be because so many people have been waiting for treatment and they find out they can't get treatment because of coverage or whatever. So we have lists of individuals waiting to get into some of those trials. So even if you sign in, there's no guarantee you'll actually get into the trial. Usually we end up with, they give us maybe 5 or 10 slots that we can enroll 5 for patients. So right now, I think we've got 6 studies that are in the pipeline for genotype 1, genotype 2, 3 patients, mainly treatment experienced and cirrhotic, but there may be. So what I do is say, there's a number there to call. The first number, 303-724-1861, that's Jennifer DeSanto. She's my main coordinator. And then she has a hotline there. You leave your message, you leave your phone number. And generally, we put your name on a list if it looks like there's a trial that fits your genotype, how much scar tissue, your cirrhosis or non-cirrhosis, whether you've been treated or not. Those are the 3 main variables. And then we try to get as many people treated as we can free. That's why I've kept this going, actually. My research interest is in a different area, but we're trying to keep this treatment unit together for the purpose of providing as much free care as we can.
In the clinical trials, do all of the patients receive the drug?
Yeah, so she's asking a good question. Sometimes in clinical trials you hear about placebos. So when we first started these trials, there were placebo arms. Okay, that is not the case anymore. Yeah, because you can see you can't have a placebo when the response rate's 99%. So basically, there's no placebo. Now, some of the studies will do delayed treatment. So in people with cirrhosis, one of the issues with the FDA has to, what does the FDA do? Does anyone know? Who here knows what the FDA does? He does. But the FDA, what is the main reason the FDA exists? It's to protect the safety, right? Safety. So they're kind of a policeman for safety, sort of, in some ways, right? Yeah. So the FDA guidelines is what dictates some of this. So one of the things that it dictates, in patients with advanced cirrhosis, they want the companies to show that the drugs are not harmful in cirrhosis. Well, how do you do that? So you have to treat one group and not treat the other group to compare side effects and complications that might arise. If you treated everybody and say 2 people had a variceal bleed, had a complication of their cirrhosis, they might say, oh, this drug is potentially toxic. It led to a bleed and a death in 2 people. So that's why you have to do this. So they do a randomized trial where one arm may not get treated for 6 months, and the other arm gets treated and followed, and then this arm will get treated later. So, but generally, I don't know of any trial we're doing today that is a true placebo or a true no treatment arm. But there are some studies that have that delayed arm.